Hi everyone, I am Dr. Sidra Osman. I've secured an AIR 1134 in Neet PG 25, and in this video we will be discussing high yield previous year questions of Neet PG, and this is going to be a very short and crisp video in which we will discuss the answers with tricks and mnemonics and in a very short and understandable way. So these questions are brought to you by Limbus Med, which is a comprehensive question bank which is highly based on previous year questions and previous year topics. And even the explanations are very short and easy to understand, so you can get the gist of the topic and you can easily revise them. So without wasting any time, let's dive into the video. The very important topic from biochemistry. So the first question is, the patient presents with tendon xanthomas, LDL more than 300 mg per dl, normal triglyceride level. Which type of hypercholesterolemia is this? Your options are type 2A, 1, 4 and 3. So the answer is type 2A, because in type 2A there is a LDL receptor defect. So LDL level increases, but there is a normal triglyceride level. So let's see why other options are incorrect. So we'll revise hyperlipoproteinemia. So in type 1 looks like L. So there's a lipoprotein lipase defect and ApoC1 defect. So 1 is 1. So ApoC1 defect, and there is C. So in serum we will see that the chylomicron level increases, which contains triglycerides. So triglyceride level increases, but the LDL level is normal. The cholesterol level is normal. Let's see in type 2A. The second letter is B. So there is a ApoB100 defect, and this is a LDL receptor defect. So here LDL level increases, the cholesterol level increases, but the triglyceride level remains normal. Let's move to type 3. So if we reverse 3, it looks like E. So there is a ApoE defect, and 3 is equal to 1 plus 2. So there are features of type 1 also and type 2 also. So tag also increases, triglyceride level increases, and cholesterol level also increases. So in this question, only the LDL level is increasing, tag is normal, triglyceride level is normal. So the answer is type 2A. Now moving on to the next question. Which enzyme complex catalyzes de novo fatty acid synthesis? Our options are fatty acid synthase, acyl coenzyme A dehydrogenase, FMGE reductase and lipoprotein lipase. So the answer here is fatty acid synthase. Even if we have to take a guess, the answer is fatty acid synthase, right? Because this enzyme catalyzes the reaction of acetyl coenzyme A. It combines with malonyl coenzyme A to form palmitic acid, palmitate. Now this acyl coenzyme A dehydrogenase is an enzyme for beta oxidation. FMGE reductase is the enzyme for cholesterol synthesis, and lipoprotein lipase is the enzyme for triglyceride hydrolysis. Moving on to the next question. In cytosol, glycolysis occurs. Which reaction is cytosolic? So your options are pyruvate dehydrogenase, citrate synthase, hexokinase and alpha ketoglutarate dehydrogenase. So the answer is hexokinase, because hexokinase is the first enzyme of glycolysis and this reaction occurs in cytosol. Let's see with the help of a diagram. So glucose enters into the cell and hexokinase catalyzes glucose into glucose 6-phosphate. Now after going into glycolysis, at last pyruvate is formed. Now this pyruvate undergoes oxidative decarboxylation in the mitochondria, and the enzyme is pyruvate dehydrogenase. Now this acetyl coenzyme A which is formed, it undergoes TCA cycle, and these two enzymes, citrate synthase and alpha ketoglutarate dehydrogenase, these are the enzyme for TCA cycle. And now these three reactions are occurring in mitochondria, so the answer is hexokinase. So moving on to the next question. Which mitochondrial process is correctly paired? Your options are beta oxidations occur in cytosol, TCA cycle in mitochondria, glycolysis in mitochondria and pentose phosphate pathway in mitochondria. So as we have seen above, TCA cycle occurs in mitochondria. So the answer is TCA cycle occurs in mitochondria. Why are other options incorrect? So beta oxidation occurs in mitochondria. This glycolysis and pentose phosphate pathway, they occur in the cytosol. So we'll see this table. So in cytosol we have glycolysis and pentose phosphate pathway. In mitochondria we have reactions like beta oxidation, TCA cycle, oxidative decarboxylation, ketogenesis. Now there are reactions which occur both in the cytosol and in the mitochondria, that is some part occurs in cytosol, some in the mitochondria. So these reactions are hugging like both of these things. So we'll remember the trick as hug, that is H for heme synthesis, U for urea cycle and G for gluconeogenesis, or you can remember as hug nu. so you don't forget, you don't confuse the G. So the answer is both occur in HUG, that is heme synthesis, urea cycle and gluconeogenesis. But here the answer is that TCA cycle occurs in mitochondria. Now moving on with pathology. So the first question is, a child with suspected iron overload shows blue granules in the Kupffer cells. This color results from reaction between iron and which compound? Your options are sulfur, potassium ferrocyanide, copper sulfate and silver nitrate. So this is talking about the Persian blue reaction, P for Persian blue and P for potassium ferrocyanide. So this potassium ferrocyanide, it reacts with the ferric ion and it forms ferric ferrocyanide, which gives the blue color. So this is the Persian blue reaction which is used for iron overload. Now moving on to the next question. A pre-malignant lesion of the lip shows metachromatic staining of mast cells. Which stain was used? Your options are PAS, toluidine blue, Alcian blue, Congo red. So the answer here is toluidine blue. It is the metachromatic stain which is used for the mast cells. So we'll remember it as कि the person gets must हो जाता है इंसान when he gets tully. So अगर so we have mast cell को will remember as must and tully will remember toluidine blue. So the person gets must जब वो tully हो जाता है. So we have toluidine blue stain for mast cell, which is a metachromatic stain. So this is the image for your toluidine blue stain, and this metachromasia is due to the heparin granules, right? Moving on to the next question. A person presents with autoimmune polyendocrinopathy, chronic mucocutaneous candidiasis and hypoparathyroidism. Which gene defect is this? So this is talking about APS1 syndrome, that is autoimmune polyendocrinopathy syndrome type 1, and this is caused due to the defect of IR gene. A for A we will remember. So this has a trick that when the body doesn't get air, it gets charred. So C for chronic mucocutaneous candidiasis, H for hypoparathyroidism, A for Addison's disease and R for recurrent candida infections. So these are the feature of APS1 syndrome, and this is due to the defect of IR gene. So without IR the body will char, right? This is the trick. Now let's look at the other options. So this FOXP3 gene, if we have a defect of FOXP3 gene, it causes IPEX, immune dysregulation, polyendocrinopathy, enteropathy, which is X-linked. So this is linked to the T regulatory cells, and this was the question in INI November 25, that the Nobel Prize was given for immune tolerance for the discovery of T regulatory cells. So the questions from immunology are asked from this topic in the recent years, right? Now this RAG1 mutation is it causes SCID, and VAS we all remember, VAS is for Wiskott-Aldrich syndrome, right? Simple. On to the next question from immunology, that is somatic hypermutation introduces. Your options are A, point mutation in the immunoglobulin variable region, B, chromosomal translocation, C, mutation in the TCR constant regions, and D, mitochondrial DNA mutations. So the answer that we must be remembering by heart, that in somatic hypermutation there are point mutations in the immunoglobulin variable regions, right? And this is due to there's an activation induced cytidine deaminase which induces the point mutation in the variable region of the immunoglobulins, and this is responsible for affinity maturation, and this causes the antibody specificity, right? Now moving on to the next question. Pancytopenia with hypocellular bone marrow is likely due to. Your options are aplastic anemia, AML, iron deficiency and hemophilia. This is the classical hallmark for aplastic anemia, that is you have pancytopenia with hypocellular marrow because there is a bone marrow failure which results in decreased cells of all the three lineages. In AML you will see hypercellular marrow because there will be increased number of blasts, and in iron deficiency anemia there would be no pancytopenia because it affects only your red blood cells, and in hemophilia is a coagulation disorder, so the cell count is normal. Now moving on to the next question. So a 55-year-old man, this is a very important question, a 55-year-old man with painless lymphadenopathy, the biopsy shows CD20 positive, a CD10 positive and BCL2 positive follicular pattern. The diagnosis is. Your options are follicular lymphoma, mantle cell lymphoma, Burkitt's lymphoma and Hodgkin's lymphoma. So the answer here is follicular lymphoma. It is the indolent B cell lymphoma which is CD1020 BCL2 positive, and you see the typical follicular architecture. In mantle cell lymphoma it is CD5 positive, Burkitt's lymphoma has c-MYC mutation and you have a typical starry sky appearance in the biopsy, and in Hodgkin's lymphoma you have the RSL. So how to remember all these mutations? For this we have the trick. In mantle cell lymphoma you have a single L, so there is cyclin D1 mutation, there is BCL1 mutation 111, and for these translocation there is a common chromosome, that is 14. So 1 and 1, एक और एक दो नहीं होते, एक और एक होते हैं 11. So there is 11:14 translocation in mantle cell lymphoma. In follicular lymphoma we have two L's together, so there is BCL2 mutation, and we will remember you are free at 18. So the translocation is 14:18. So the answer here is, because the typical BCL2 word is given, so the answer here is follicular lymphoma. In Burkitt's lymphoma we will remember it with Burkitt, and kid is a child, so we see c-MYC mutation in Burkitt's lymphoma. Hodgkin's lymphoma are CD15 positive and 30 positive, right? Now moving on to the next question. A 50-year-old male presents with proteinuria, edema, thickened GBM, and on electron microscopy it shows subepithelial deposits. Your options are membranous glomerulonephritis, FSGS, minimal change disease and IgA nephropathy. So this is a typical proteinuria, edema and thickened GBM. So this is mainly talking about your nephrotic syndromes. So IgA nephropathy is out of the option, and electron microscopy it is showing subepithelial humps. So you don't see anything as such in minimal change disease except for diffuse effacement of podocytes. So minimal change disease is out. And now you have two options, membranous glomerulonephritis and FSGS. So the answer here is membranous glomerulonephritis. So we will remember subepithelial humps. In subepithelial humps you have epi mein we have P. So there are 3 DDs for subepithelial humps in the electron microscopy, that is PSGN, it has P, RPGN mein we have P, and one thing just that you have to remember, it is membranous nephropathy, membranous glomerulonephritis. So the answer here is PSGN and RPGN are type of nephritic syndrome. So the answer here is membranous nephropathy, and thickened GBM, spike and dome appearance, these are the feature of membranous nephropathy, right? Moving on to the next question. A young adult with hematuria, low complement and tram-track appearance on light microscopy. What is the diagnosis? And the options are membranoproliferative glomerulonephritis, post-streptococcal glomerulonephritis, IgA nephropathy and minimal change disease. So the typical word, the tram-track appearance, it is used for membranoproliferative glomerulonephritis. We will remember कि membrane है, membrane is proliferated, so you have a typical tram-track appearance in membranoproliferative glomerulonephritis. As you can see in this picture, there is a proliferation of membrane. There is a GBM splitting which causes the tram-track appearance in the light microscopy. And on immunofluorescence you are going to see a granular deposit, so there is a low level of C3, low level of complement, and on electron microscopy it depends on the type of MPGN. Moving on to the next question. A neonate presents with generalized erythema and superficial skin peeling, sparring the mucous membrane. The responsible toxin is, your options are TSST1, enterotoxin, exfoliatin and alpha toxin. So you must have made the diagnosis that this is SSSS, that is staphylococcal scalded skin syndrome. So here what happens is you have the toxin exfoliatin. We will remember ki exfoliating is exfoliation, that your skin is getting removed. So the answer is exfoliatin. So this exfoliatin, it cleaves the target antigen, that is desmoglein 1. So there's superficial peeling of the skin and there's a true Nikolsky sign. Why are other options incorrect? So in T1, you have a history of tampon, T for tampon, and S for there is a history of shock also. You don't have such thing in the option. So so the answer here is exfoliatin. In enterotoxin, it obviously enterotoxin will cause GI symptoms, and in alpha toxin it causes the membrane damage. With this thing we will move on to the next question, that is which staphylococcal toxin causes pore formation in the host cell membrane. We know it from the explanation from the above question itself that the answer here is alpha toxin. So another way to remember this toxin is that in alpha we have P for P, that is alpha may we have P. So it causes pore formation in the cell membrane, or it causes damage to the cell membrane. Other toxins mechanism we have studied in the above question, right? Moving on to the next question. Investigation of choice for genitourinary TB is. Your options are urine routine microscopy, ZN stain of urine, IVP, urine culture of AFP. So the answer here is D option, urine culture of AFP, because culture generally has more sensitivity and specificity. So the answer here is urine culture for AFP. Because ZN staining has a low sensitivity, and this urine culture for AFP, it is the gold standard. Moving on to the next question. A patient with sharply demarcated erythematous painful skin lesion with fever is diagnosed with St. Anthony's fire. The causative organism is, so here buzzword is painful skin lesion, and you have St. Anthony's fire. So these two words are used for erysipelas, right? So your options are Staphylococcal aureus, Streptococcus pyogenes, Clostridium perfringens, and Erysipelotheryx. So the answer here is, because this is talking about erysipelas, right? So it is caused by GABs, that is group A beta hemolytic streptococci. So the answer here is Streptococcus pyogenes. Let us differentiate erysipelas and erysipeloid. So erysipelas is a painful lesion, sharply demarcated painful lesion, and there is a history of St. Anthony's fire. So this is your erysipelas, which is caused by group A beta hemolytic streptococcus, and erysipeloid, it is caused by Erysipelotheryx roseopathicae, and there is a history of fish or meat handlers. So this is how you differentiate, right? Moving on to the next question. A 4-year-old child with HIV presents with the chronic watery diarrhea. Modified acid-fast stain shows small round oocyst 4 to 6 micrometer in size. Which parasite is this? Your options are Cyclospora, Isospora, Cryptosporidium, and Giardia. So the answer here is Cryptosporidium. Let's see how. Because it has a small round oocyst which is acid-fast positive, that is 4 to 6 micrometer in size. So the answer is Cryptosporidium. And the diarrhea is occurring in an immunocompromised patient because there is a history of HIV positive child. Now in Cyclospora, the size of the oocyst is a little large. It is 8 to 10 micrometer. In Isospora, it is larger in size, or even more large, that is around 25 micrometer it is. So I have remembered it like 5, 10 and 25, Cryptosporidium, Cyclospora, Isospora, right? Now, and Giardia is non-acid fast, so that is how you rule out this option. So first of all, let us take a look. So if a person presents to you with a history of diarrhea in HIV patient, so your DD can be Cryptosporidium, Cyclospora, and Isospora. So the size of the oocyst is 4 to 6 micrometer, 8 to 10 micrometer, and 24 to 36. So as I've told you, we'll remember the average value 5, 10, and 15 micrometer. Now if we complete C, it becomes O, that is in Cyclospora and Cryptosporidium, the shape of the oocyst is round, whereas in I, if we complete around it, so it becomes like oval shape. So the answer like the oocyst here is oval shape. Now we'll remember that the treatment for these is, for Cryptosporidium, the treatment of choice is nitazoxanide, and for Spora brothers, Cyclospora and Isospora, the treatment of choice is cotrimoxazole. For Spora brothers, we will remember that both of them, they have a sporocyst, they have autofluorescence, and the treatment is cotrimoxazole, right? We'll also remember that Isospora is acid fast positive. With this knowledge, we will move on to the next question. That is, a patient presents with the prolonged watery diarrhea, improves only after cotrimoxazole. Stool shows oval acid fast oocyst. The diagnosis is, your options are Cryptosporidium, Isospora belli, Cyclospora, and Enteromoeba histolytica. So we have discussed the explanation in detail, that if there is an oval cyst, that is acid fast positive. So the answer here is Isospora belli. You can see the explanation as well, and it is responding to cotrimoxazole because Spora brothers respond to cotrimoxazole. The Cryptosporidium does not respond well because the drug of choice for that is nitazoxanide, and Cyclospora is partially responsive to it, right? Now, and Enteromoeba, it causes dysentery, right? Moving on to the next question. Now we have PSM. So comparing average hemoglobin level between males and females, it requires, so it is the question of statistical test, very important topic, paired t-test, unpaired t-test, chi-square test or correlation. So we'll remember this. So the answer here is unpaired t-test, because these are two independent group and the hemoglobin is a quantitative data. So let's see how we proceed with these questions. So in first of all, we will look at the variable. Variable, if it can be measured or if it cannot be measured. So if the variable can be measured, it is a quantitative variable like height, weight, hemoglobin. These have particular values. So these are quantitative variables. So if you have a quantitative variable, then you look at the number of groups. So if you have two groups like male, female, pregnant, non-pregnant, so it is a t-test, t for 2, right? Now we will see if the question is talking about before and after that. If you give IFA, the hemoglobin increase from this to this, then it is a paired t-test. But the question here is not talking about that. The question here is male and female, that is we have two groups and the question is just talking about them. So these are the answer is unpaired t-test, right? So if there are more than two groups, the answer is ANOVA test. So this is about the quantitative variable. First of all, the quantitative variable is hemoglobin. There are two groups, male and female, no before and after. So the answer here is unpaired t-test, right? Moving on to the next question. Association between smoking status and lung cancer is best analyzed using, your options are t-test, Pearson correlation, chi-square test and ANOVA test. So let's see. So as I've told you earlier, firstly look at the variable, if it is a qualitative or quantitative. About the quantitative we have discussed in the above question. Now about the qualitative variable. Now this qualitative variable is there, then we will look at the sample size. So if the sample size is large, that is more than 30, then the answer is chi-square test. If the sample size is small, then the answer is Fisher test. Now here the about the sample size, it is not mentioned. So if anything like that is not mentioned, the answer is chi-square test. And this is talking about smoking and lung cancer, and both of them are qualitative variables. You cannot measure them, right? So the answer here is chi-square test, right? Moving on to the next question. The midday meal program targets children of which age group? Your options are 0 to 5, 6 to 10, 6 to 14 and 10 to 18. So midday meal program is for class 1 to 8. So the answer here is the age group is 6 to 14. You have to remember this. Now moving on to the next question. The vaccine vial monitor, it indicates, your options are sterility of vaccine, expiry date, cumulative heat exposure and freeze damage. So the VVM is used for cumulative heat damage, like it is used for heat sensitive vaccines. So it indicates your cumulative heat damage. The chemical used here is PTS, para-toluene sulfate, and VVM shows heat exposure over time, and it is an indirect marker of potency. You have a round circle and inside you have a rectangle. So when the colors become same or it becomes darker, you have to discard the vaccine, right? So it shows cumulative heat exposure, right? Moving on to the next very important topic, that is arrhythmias. So the question is, atrial fibrillation on ECG shows, your options are A, irregularly irregular rhythm with absent P waves. Next option is narrow QRS with sawtooth P waves. Third option is regular rhythm, normal P waves. And the last option is wide QRS and regular rhythm. So the answer here is irregularly irregular rhythm with absent P waves. This is typical for atrial fibrillation. Why are other options incorrect? So this sawtooth P waves, these are seen in atrial flutter, and you can never see regular rhythm in atrial fibrillation. This is not a feature for AFib, right? Now the next question is, MAT differs from atrial fibrillation by, your options are presence of discrete P waves with varying morphology, irregularly irregular rhythm without P waves, wide QRS complex and fixed PR interval. So for MAT, the answer is there are different P wave morphologies, more than three different morphologies for P waves. So the answer here is A option, right? So the explanation is that in MAT you see at least 3 distinct P wave morphologies. If P waves are absent, then it is atrial fibrillation, and wide QRS complex is a feature of ventricular tachycardia. PR interval is variable in MAT. So for MAT, we will remember MAT has 3 letters, and the third letter is C. So the drug of choice is calcium channel blocker. There's a history of COPD, and in the patient cardioversion is contraindicated. And we will also remember that since MAT has 3 letters, so there are 3 or more than 3 varying morphologies of P waves. So with the letter 3 and C, we will remember all the features about important features about MAT, right? King's College criteria for acetaminophen induced ALF, acute liver failure. It includes, your options are pH less than 7.3 or PT more than 100 seconds, creatinine more than 3.4. Option B is MELD more than 40, C Child-Pugh C, and D is INR only. So the answer here is option A, pH less than 7.3, PT more than 100 seconds, or creatinine more than 3.4. It indicates the poor prognosis and the need for transplant. We can remember this as, so in the case of PCM induced poisoning, that is acetaminophen induced acute liver failure, if it requires the need for liver transplant, we have the King's College criteria. So it includes 4 things. PICA we will remember, that is P for pH, I for INR, C for creatinine level, and A for altered mental sensorium, or we will remember altered mental sensorium, that implies encephalopathy. So these are the criteria which are required for acetaminophen induced acute liver failure, right? So moving on to the next question, hematemesis in variceal bleed is managed initially by, your options are airway protection, IV fluid, vasoactive drugs, endoscopy only, PPI only, and the last option is observation. So when the patient comes to you with acute variceal bleed, it is very important here in the question, your buzzword is initial management. So initial management is always the stabilization of the patient. You will do ABC, airway breathing circulation, that is, so the answer becomes airway protection, IV fluids, and vasoactive agent. After the stabilization of patient, we perform endoscopy, per GI endoscopy. We will treat the patient with either banding or sclerotherapy, right? Moving on to the next question. So a 25-year-old presents with edema, proteinuria more than 3.5 grams per day, hypoalbuminemia, hyperlipidemia. Most likely initial management includes, your options are ACE inhibitor diuretics, option B is immediate dialysis, C is immunosuppressants only, and your last option is loop diuretics only. So this is the case of classical nephrotic syndrome. You have hyperlipidemia, you have proteinuria, you have edema. So the diagnosis is the classical nephrotic syndrome, and it is asking about the initial management. In initial management, the answer is ACE inhibitors and diuretics. So ACE inhibitors are given to reduce the proteinuria, and this to reduce edema we give diuretics, right? Dialysis is done in the later stages when the kidney goes into renal failure. Immunosuppressants are used for specific causes like FSGS and membranous nephropathy, and not here, right? So the answer is ACE inhibitors and diuretics. Moving on to the next question, a 12-year-old boy with hematuria, sensorineural hearing loss, and family history of kidney disease is most likely to have. So your options are Alport syndrome, IgA nephropathy, post-streptococcal glomerulonephritis, and minimal change disease. So very important thing, so the answer here is Alport syndrome, because in Alport syndrome we have a triad SNHL, NTL lenticonus, and the patient presents with a kidney problem, here hematuria, that is the most common thing, and is a X-linked condition, X-linked dominant condition. So it would have a family history. So in this question it is typically given the patient has a family history, the patient has SNHL and hematuria. So the answer here is A, Alport syndrome, right? So IgA nephropathy, in IgA nephropathy you will not have a history of hearing loss, right? In minimal change disease it is a nephrotic syndrome, so there would be no hematuria, and PSGN it is caused due to infection, and it is a self-limited condition, right? So moving on to the next question, a CKD patient with a persistent hyperkalemia, metabolic acidosis, and fatigue is being evaluated. Most sensitive indicator for early CKD is, your options are eGFR, serum creatinine, BUN, and urine analysis. So the answer here is eGFR, because eGFR it detects the early renal dysfunction. It is very sensitive, and even before the creatinine level rises, you can easily diagnose it with eGFR because it has more sensitivity, right? BUN is influenced by diet and hydration, and urine analysis, it misses the early CKD, right? Moving on to the next question. A 28-year-old presents with the relapsing remitting weakness. So the weakness is relapsing and remitting, diplopia and paresthesia. MRI shows periventricular white matter lesion. CSF shows oligoclonal bands. So the diagnosis is, your options are multiple sclerosis, neuromyelitis optica, acute disseminated encephalomyelitis, and D option is GPS. So the typical words are oligoclonal bands, the patient has periventricular white matter lesion, relapsing remitting weakness. So it goes towards the diagnosis of multiple sclerosis. So the answer is multiple sclerosis. In multiple sclerosis, it is giving relapsing remitting kind of course, CNS lesion, oligoclonal bands. This neuromyelitis optica, it is optico-spinal disorder. In this you have bilateral optic neuritis, spinal involvement of more than 3 segments. Multiple sclerosis also has optic neuritis, but it is generally unilateral, right? ADEM is monophasic, that is acute demyelinating encephalomyelitis, and GPS causes peripheral neuropathy. So moving on to the next question. A 40-year-old develops acute symmetric ascending weakness over 3 days after a viral infection. So there's a history of viral infection and the patient has acute symmetric ascending weakness. Reflexes are absent. Most likely diagnosis is, your options are Guillain-Barré syndrome, stroke, MS, peripheral neuropathy. So the answer here is A option, Guillain-Barré syndrome. So because this is the classical history for Guillain-Barré syndrome, you have a history of post-infection, the patient has demyelinating neuropathy, reflexes are absent, that is DTRs are reduced. So this typically goes for option A, Guillain-Barré syndrome. Now stroke causes focal lesions, right? In stroke you would have stroke is focal in nature. MS may central nervous system gets affected, not the peripheral nervous system, and so the peripheral neuropathy, and the peripheral neuropathy itself, it is chronic in nature, right? So the answer here is, it is a typical history for Guillain-Barré syndrome, right? Moving on to the next question. Which parameter best indicates adequate fluid resuscitation in shock? Your options are BP normalization, CVP more than 12, urine output more than 0.5 ml per kg per hour more than equals to, and option D is normal lactate. So acute fluid resuscitation in shock, the best option is urine output more than equals to 0.5 ml per kg per hour. It is the earliest and the most reliable perfusion marker, right? Moving on to the next question. QSOFA score, very important. QSOFA score includes all except, your options are SBP less than or equals to 100 mmHg, respiratory rate more than equals to 22 per minute, altered mental sensorium, and the option is serum lactate. So the answer here is serum lactate. Lactate is not a part of QSOFA score. So what are the constituents of QSOFA score? So QSOFA score, we'll remember with the trick, there's a cute sofa in a bar. So cute sofa means QSOFA, and the trick is bar, that is BP. A for altered mental sensorium, R for respiratory rate, that is SBP less than equals to 100 mm of Hg, A for altered mental sensorium, that is GCS less than 15, and R for respiratory rate more than or equals to 22 per minute. So cute sofa in a bar, in the it includes bar, BP, altered mental sensorium, and R for respiratory rate. Moving on to the next question. Classical triad of Boerhaave syndrome includes all except, your options are vomiting, chest pain, subcutaneous emphysema, and hematemesis. So it is talking about Mackler's triad. So the Mackler's triad, the trick is CVS, that is C for chest pain, V for vomiting, and S for subcutaneous emphysema. So the answer here is hematemesis. Hematemesis is not a part of the Mackler's triad, right? So Boerhaave syndrome is the spontaneous esophageal perforation, right? Moving on to the next question. Best investigation for suspected Boerhaave syndrome is, your options are barium swallow, endoscopy, CT chest with contrast, and D is plain X-ray. So the answer here is, you do contrast study, that is CT chest with contrast. It is the investigation of choice. It detects the leak plus mediastinitis. We don't do barium swallow because it can risk contamination. We don't do barium swallow here. Moving on to the next question. Zuska's disease primarily involves, so your options are lactiferous sinus, TDLU, terminal duct lobular unit, subareolar ducts, and D is Cooper's ligament. So the answer here is C, subareolar ducts. This Zuska's disease is the squamous metaplasia of subareolar ducts and there is a recurrent periductal abscess. So the patient has बार उसको recurrent periductal abscess रहेगी. Lactiferous sinus is the dilated portion of your subareolar ducts, right? TDLU, it is the unit from where the carcinoma of breast arises. So this is not the answer. Cooper's ligament are for a fibrous support of the breast. So the answer, that is Zuska disease, it involves subareolar ducts, right? The next question, most common presentation of Zuska's disease. Your options are painless lump, bloody nipple discharge, recurrent subareolar abscess, and the option is skin ulceration. So the answer here is, we have read in the explanation in the above question that the answer here is in Zuska's disease you have recurrent subareolar abscess. So the answer here is recurrent subareolar abscess. This is the feature for Zuska's disease. Now bloody discharge from the nipple, it suggests ductal papilloma, and painless lump, it suggests fibroadenoma. Okay, now moving on to the next question. First line management of non-invasive bladder cancer, that is TA and T1 is, your options are radical cystectomy, TURBT, radiotherapy, chemotherapy alone. So the answer here is that for the early stages of bladder cancer in which the muscle is not involved, that is TA and T1, the answer is TURBT, transurethral resection of bladder tumor. So it is when the muscle is not involved, that is the early stages of cancer, TA and T1. So if the muscle is involved, the stage is more than or equals to T2, that is T2, T3, T4, more than that, the answer is radical cystectomy plus bilateral pelvic lymph node dissection plus urinary diversion. Okay, now moving on to the next question. In twin pregnancy, dichorionic diamniotic twins, it results from, your options are 2 zygotes, 1 zygote splitting in less than 3 days, 1 zygote splitting 4 to 8 days, monochorionic placenta. So the answer is 2 zygotes. DCDA, that is dichorionic diamniotic twins. These are the most common type of twin pregnancies. They have 2 separate placentas, they have different amnion, different chorion, and this is formed from 2 zygotes, right? Moving on to the next question. HELP syndrome is characterized by, option A is hemolysis, elevated liver enzyme, low platelet count. Option B is hyperemesis, edema, low platelet. Option C is hypertension, edema, liver enzyme elevation, and option D is hyperbilirubinemia. So the answer here is, we know that the full form for HELP syndrome is H for hemolysis, E for elevated liver enzyme, LP for low platelet count. So the answer here is A. It is the severe variant of preeclampsia with multisystemic involvement. So the answer, full form itself, that is the HELP syndrome. So guys, this was the MCQ discussion video. I hope you liked the video. So this QBank is brought to you by Limbus Med. As you can see in the video, the explanations of the answer are very short, crisp, and very easy to understand. So Limbus Med is bringing to you a very good offer, that is you can avail the app at $299 per month or $999 per year. That is a very affordable price. So if you like the questions, the answers, and if you want a predictive PYQ series and a typical QBank that is based on PYTs, then you should opt for Limbus Med. I hope you like the video. See you in the